I just want to thank everybody for sending in your questions. I've had a chance to review those ahead of time and done my best to try to cover as many of the topics that came up in the questions ahead of time. And I'll do my best to leave room for some questions at the end as well if there is anything that I haven't addressed. Love this quote by Robert Frost. "I have promises to keep and miles to go before I sleep," which I think really just speaks to the work that all of us do in our lives. And as we approach the end of our lives, thinking about the closure, people, and things around us that are important to tend to as we approach those final stages. So just to give you a little bit of an overview and sort of how palliative care came about as a field, one of the questions that I frequently get is, tell us about the difference between hospice and palliative care. While there are a lot of similarities and overlap, there's also a lot of key differences as well that I think is really helpful for people to understand. So over the last few decades, particularly during my training, there's been a lot of interest in end-of-life care, and it has developed as its own sort of medical specialty. This is important because over the last 100 years, things have changed very drastically in our country. People are living a lot longer. Just to give you an example, in 1900, people were lucky to make it to the age of 50. Most people lived until their sort of late 40s. At the year 2000, people were living into their 70s, which is certainly a bit of an improvement. And what that means is that we have people living for longer periods of time. This graph just shows, again, how life expectancy has changed over time. You can see that around 1880, there was a sort of rise in life expectancy at that time, and that was really attributed to the development of modern sanitation. So when we learned to keep our dirty water and our clean water separate, it had a huge impact on life expectancy. In the 1920s is when antibiotics were developed, and that drastically changed things as well. People were no longer dying of infections, and people's life expectancies rose significantly after that. What you can see is from about the 60s to our current time is that things have really plateaued around the mid to upper 70s. And the impact of this is, again, that there's been sort of an unprecedented growth and needs in people who are chronically ill, especially those who are aging. And not only that, but this sort of growing older population has been paralleled with an increasing use of medical technologies. Medical technologies have become more available and more widespread, and the impact of these is that they sometimes prolong life, not always with restoring health or functional independence. And so our technologies and modern medicine have drastically changed our experience of severe illness and even more so how people die. So why is this an important issue? Our technologies and the fact that people are living longer, I think, creates a lot of anxiety that somehow death can be prevented, and that just with the right care and the right technologies, people can live longer. And been doing this work for a long time now, and I'm still pretty certain we've never come up with a cure for death. People have been living longer and dealing with more over time, though, in the face of all these greater treatments that are out there. This often leads to people really sort of seeking second opinions, wanting to hear from another provider, seeking out research centers, for example, and even trying experimental treatments. And all of this, in my opinion, has really led to a great deal of anxiety that leads to overuse and excess costs at the end of life as well. And this has really led, I talked about how there's been such a shift in our culture. It's moved things away from private residences and homes, more into medical facilities and centers. So more than 70% of all Americans actually die in either a hospital or a nursing home. We know that that's tends to not be people's number one preference. Most people, if you ask them, say that they would prefer to die in their own homes. And even more sort of troubling in many ways is that many of these deaths are preceded with a period of time in intensive care, which again means that people are receiving more advanced therapies closer to the end of their lives. I mentioned that this leads to significant cost. So these treatments and therapies in ICUs are often very expensive, and we lead the world in healthcare dollars spent. You may think that that would lead to greater satisfaction at the end of life, but what we've found is that actually the opposite exists. Despite high spending, dissatisfaction with the care at end of life remains very high. And the way we experience death again has changed drastically. For many parts of the world and in our own country, for many years, there were routines and rituals that helped people to get through the dying process, to bereave and to reintegrate into our society. Again, as people have been, as medical care has become more removed from public spaces and takes place in private hospital rooms, many of these rituals and experiences have also dwindled. Many young people have never had the experience of watching a loved one die. So while death used to look like this in much of our country and throughout many parts of the world, it's become and started to look a lot more like this. And again, I don't mean to diminish the benefits that some of these therapies might have, but I think it really worries people and certainly leads to this understanding that that there are limitations of modern medicine, especially around the needs of seriously and chronically ill people. This is a photo of Marion Babigan, who would have been my mother-in-law, unfortunately died before we were able to marry. But in 2005, when I was a medical student, I was actually on a pediatric rotation at Hasbro Children's Hospital in Providence and received a call letting me know that Marion had collapsed. She had been rushed to the emergency room. I might get a little emotional, excuse me. Had been rushed to the emergency room, and I received many frantic calls from family saying that she was on life support, she was unresponsive, and family was very understandably anxious about how she was doing. I was early in my medical school, didn't have a lot of training, and I was on pediatrics. End of life was not something that I had much experience with. So I rushed down to New Jersey, to the hospital where she had been admitted, and then spent the next several days in the ICU, grappling with what choices to make. And the thing that was hardest for us was that Marion was the most organized woman that you would ever meet. I mean, you could see her platters of food behind her. She was known for throwing dinner parties and would plan everything to a T. She kept house better than anybody I've ever met, and was just so diligent with all of her activities, including completing living wills and advance directives. So we knew when Marion collapsed that she had an advance directive that was in a drawer, neatly filed and organized. I mean, she could not have made things easier for us. And she was very clear: if I have an irreversible condition, do not keep me alive through the use of life-sustaining treatments. We knew that was her wish. What we didn't know was what her prognosis was. Was she in an irreversible state? Was this a terminal condition? We knew that she was seriously ill. It took many days of heartache and a lot of angry discussions with staff members who just couldn't give us the information or wouldn't give us the information. We just needed to know what her prognosis was so that we could make the decisions we needed to. And it wasn't until many days later, and probably many angry outbursts from my family, that a neurologist came in and sat down with us in a conference room. He took the time. I think it was about a 30 to 45-minute discussion. I don't know how long it was, but it didn't feel rushed. And he gave us the time that we needed. And he gave us the very difficult information that we had to hear to help us make those decisions. It wasn't until years later that I was in my residency and actually had a rotation in palliative care that it dawned on me that what that doctor did for us that day was palliative care. He sat down with us. He, in a very compassionate way, presented all of the medical information to us. He talked about what we knew, what we didn't know, what was certain, what was not certain. That allowed us to make the difficult decisions and move forward with caring for Marion in a way that she would have wanted. It was a hard loss, but it was much harder feeling like we were keeping her in a state that she was not okay with. Once we were able to move forward, we were able to breathe and to grieve. And what the experience did was raise this idea of suffering to me, which, we all know that physical pain is a form of suffering, but suffering as a word means much more than just that. The suffering that my family was experiencing in that situation was around lack of communication, lack of feeling like there was sort of cohesive support, and feeling like we weren't honoring somebody's wishes, somebody who meant so much to all of us. So this concept of suffering was really really well articulated by this woman named Cicely Saunders, who's really the mother of the modern hospice movement. So Cicely Saunders started as a social worker in England. She helped found St. Christopher's Hospice, which is the first hospice in the world. And while she started as a social worker, she went back and received additional training, eventually became a nurse, went back to receive additional training, and eventually became a physician. And she really coined this concept of total suffering, that when somebody is exhibiting a physiological symptom, so if somebody's in pain or looking like they're anxious, that there are often multiple layers to this. It's not just physical. There's psychological needs, social needs, often spiritual needs as well. She also coined this idea of what is a good death. While Cicely Saunders was working at a time when ICUs were in vogue, were becoming the thing, and were really being looked at as the sort of the answer to a lot of our medical problems, and recognize that there can be good deaths and there can be bad deaths. And while for some people the idea of any death is hard to fathom as a good thing, we know it when we see it. When you're surrounded by the people, places, and things that are important to you, spending time the way you want, certainly not experiencing any sort of therapies or interventions that don't align with what's important to you. But this is a real challenge. Good palliative care is challenging for lots of reasons, and the biggest being prognosis. It's really hard to know what is going to happen for any individual with their illness. And most doctors are not trained to really think about this. So medical education focuses mostly on diagnosis and treatment. If you open any medical textbook, you'll see that that upwards of 90% of all medical education is really focused on how do you diagnose something and what's the treatment. Very little attention is given on prognosis and how do you think about prognosis, how do you communicate prognosis. But everything hinges on prognosis. If you have 10 years to live versus 10 minutes, you're going to make different decisions. It's hard because certain diseases are really marked by exacerbations over time. People look really sick but get better. How do you know when is going to be that last time for an individual? And doctors have a hard time with this. And doctors who know their patients for a long period of time tend to be optimistic and tend to overestimate prognosis. It's just a function of knowing and caring for somebody. These are some graphs that just give examples of how illness changes over time. So this is an example of what we often see with cancer. So on the y-axis is function, on the x-axis is time. And what it shows is that early on, when people are first diagnosed with cancer, for example, they tend to be pretty functional. Many people are working, going about their lives when they encounter these diagnoses. Over some period of time, function starts to deteriorate. And for many cancers, particularly the solid tumors, metastatic cancers, when function starts to deteriorate as a result of that cancer progressing, that functional decline begins to worsen and tends to be a very significant deterioration for many people. These curves have been looked at, and what people found early in cancer research is that when that decline starts to happen, people on average have about 6 months to the time of death. So this is actually where the hospice benefit came about, was recognizing that for cancer patients, and when you start to see that functional decline, and very often you're looking at a prognosis of months. What's challenging is that not all conditions and many of the things people are dying of don't follow cancer's trajectory. So this is an example of what happens with conditions like heart failure or COPD, which are more commonly the illnesses people are experiencing and living with for long periods towards the end of life. So you see that over time, people have these dips. Those are the exacerbation. When somebody gets really sick, they go into the hospital, are really dependent on nurses and staff to care for them. But many times people rebound and they improve from those exacerbations and go back home. I think some key things is that you see that overall the trend on that graph is a downward one. When somebody's been in the hospital for their fourth or fifth heart failure exacerbation, they're usually not sort of getting back to the same levels they were, before these things started. Overall, you tend to see function worsening. The hard thing is that any of those dips could potentially be a life-threatening or life-ending event, and it can be really hard to predict. Those exacerbations can happen over the course of years, and so really kind of knowing where somebody is on that trajectory is a challenge. Then you have conditions like dementia, so things like Alzheimer's, Lewy body dementia, types of vascular dementias, strokes, where people have a low level of functioning as a result of this illness, but that can really be a prolonged decline. And for many patients with Alzheimer's dementia, for example, the life expectancy from the onset of symptoms to death can be many years. So again, trying to know exactly where somebody is along that pathway can be hard to recognize and to communicate. The word palliate is something I get asked about often, and it comes from Latin, palliare, which means to reduce the violence of a disease. In other words, to cause, to lessen or abate, to ease without curing, to moderate the intensity of. So palliation is all about the relief of suffering, and again, not just physical suffering, but suffering across the board. The World Health Organization defines palliative care as an approach that improves quality of life for patients and their families with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, including physical, psychosocial, and spiritual. I think important to note here is that it says nothing about dying. There's a lot of emphasis actually on life and quality of life. Granted, for patients who are facing life-threatening illness, we're dealing with complex illness, but many people are not necessarily ready to be at the end of life, and that might not be what people are hoping for, but yet there could be suffering experienced regardless of where people are in the course of their illness. So these two graphs, I think, really kind of summarize very nicely sort of the differences between hospice and palliative care. So the top graph shows kind of what used to happen before palliative care became a field. So you see on the top area, there's this active aggressive intent. So somebody's diagnosed with a serious illness. There's often a period of managing that illness medically, including hospitalizations, surgeries, interventions as necessary. There comes a time perhaps when those therapies are no longer working. So there's, in the past, there used to be a very abrupt shift from aggressive intent to palliative intent. So that used to be how things were. People received aggressive treatment. At some point that stops working, or they're no longer sort of interested in pursuing those things. That window of palliative intent is often hospice care in many situations, followed by death, and then a bereavement period for the survivors of that individual. I think the top graph gives the false impression that that active and palliative intent are sort of used in equal proportions. The opposite is actually true, that the period where people pursue active and aggressive intention is usually pretty prolonged. And the shift towards sort of hospice or a palliative intent typically happens in the very few days preceding death. So what this meant was for many, many years, and still happens in many situations, that people aren't referred to hospice care or even sort of thinking about palliative intentions until those very final days of life. What people have recognized is that there are needs that exist throughout. So if you look at the graph below, the B graph, when somebody is diagnosed with a serious illness, there may be a very limited role for sort of palliative interventions at that time. But rather than having this abrupt transition from one type of care to the other, it should happen gradually over time. So, somebody is diagnosed with an advanced serious cancer, the palliative portion of that care early on might be completing advanced directives, letting us know who your healthcare power of attorney is, maybe doing some thinking about what how you may want to handle various scenarios going forward. But the majority of your care may be handled by your oncologist and your primary care physician. As things progress over time, the role for the palliative portion of your care may start to increase. You may have more symptom needs. Your family may be really struggling with your decline. And so the role of palliative physicians and social workers may start to become more important, whereas that sort of disease-directed medical care might be less important over time. But the hope is that people will sort of transition over time and really benefit from the expertise of all those team members who are really sort of core and key to the hospice type of model. So while palliative care is kind of this notion has really existed since the hospice movement started in the 60s, it wasn't actually until the early 2000s that hospice and palliative medicine became recognized as a specific medical specialty. So what this means is that in order to be a hospice and palliative care physician these days, you have to complete a fellowship following your residency. I spent 3 years training in family medicine, and I completed a 1-year fellowship in hospice and palliative care following that. These days, anybody who wants to sit for the boards and become board certified has to complete one of these fellowships. So it's an additional year of training. There are some fellowships that may be a little bit longer than that. Some, for example, that work with pediatrics or more specific populations. But in general, it's an extra portion of training once you've already completed your primary medical training. And again, just to sort of summarize, palliative care can really happen at any time in the course of a patient's illness, regardless of prognosis. So somebody might be very seriously ill in the hospital, the potential that they could die, but that person could also have the potential that they get better. And palliative care could still be very helpful in those situations. And it can happen alongside curative treatment. So again, before, the oncologist wouldn't call us until they were finished offering their chemotherapy. Now we recognize that both things can happen simultaneously. Patients can be supported, can have important conversations to help support them and their loved ones plan for the future while still receiving some of these therapies. Hospice is a specific insurance benefit and really is hinged on prognosis. So to be eligible for hospice, you have to have a prognosis of 6 months or less. A hospice physician and your attending physician both have to be in agreement that that's the expected prognosis, and you elect this benefit. You sign a consent form that says you're allowing your insurance to cover these services. The hospice physician, again, is somebody who has expertise in end-of-life care, and your primary physician may have some knowledge, but their sort of input and role might change over time as things change and sort of input, the need for input changes. So my role might be very limited when somebody first comes onto hospice. Many patients continue to see their primary care physicians, and we want that to happen. If you have a strong relationship with somebody who's known you for years, why would you want to stop that when you come onto hospice? That's a very important relationship to continue. However, the input of people who perform this care regularly, becomes more important over time. And so it's a collaborative effort. Coming onto hospice does not mean that you need to stop seeing your physician. It means that your physician will be collaborating with us as things change over time to help figure out what are the most important aspects of your care. Some of the similarities is that we share a similar philosophy. So both hospice and palliative care is really focused on maintaining and managing quality of life. So in the face of serious illness, how do we really make each day the best? And both rely on a team. We recognize that sort of the medical model of, understanding our physiology is important, but human beings are much more than that. So it takes nurses, social workers, clergy. At hospice, we have, nurses, aides, and volunteers, you name it, who are really sort of key players in caring for people as things change over time. In fact, my role as a physician may be very limited in a lot of patients that we care for. So it takes a team. It really takes a village. And it can happen in a variety of settings. It can happen in hospitals, homes, clinics, long-term care settings, such as nursing homes. I spend part of my time as medical director for hospice, but I also work in the hospital at Maine Medical Center, where I do palliative care consults. And there, likewise, I'm part of a team. We consist of physicians. We have a number of nurse practitioners and PAs who work with us. 2 social workers who are full-time and really skilled, and they have additional training and sort of helping families and patients sort of cope with serious illness. in particular, sort of non-pharmacological interventions. They're really great at various therapies that can help to alleviate things like pain and anxiety without having to use medications. Our chaplains play a real key role for so many of our patients. Then we collaborate with other people in the hospital. So we have, for example, a PACT team, which focuses on serious illness for children. We have child life specialists, both for young people who may be sick, but also for family members of patients. So, we had a 29-year-old who died in our facility just over the weekend, and he had a young child at home. And, how do you support that young person? So we bring in specialists to help sort of identify and meet the needs of families. Other services that help complement us are geriatric service. We have a wonderful OMT program in the hospital that's really great. Osteopathic physician, doing manipulation to help with pain, things like Reiki therapy, animal therapy, music therapy. But again, recognizing that the medical care is not the end all and be all. Some of the reasons that we get consulted is to help clarify goals of care. Many of you have probably had the experience of seeing providers in different settings. You might see a specialist in one office, a surgeon somewhere else, and feeling like people aren't talking together, and that things seem to be headed in multiple different directions. So one of the things we do is gather all the relevant people to get on the same page about what it is we're trying to achieve. What are the goals in the hospital? Are we trying to restore somebody to their highest level of health and function? Are we trying to alleviate pain and suffering? Are we helping to prepare for a good death? Again, goals change depending on what somebody's prognosis is and what matters most at that time. We help with things like advanced care planning. So we help people complete living wills. We help complete some of the legal documents, around like medical power of attorney. Help thinking about sort of maybe finding legal guardians for individuals whose capacity may be changing over time, but really starting to think about what kind of legal documents might need to be put in place to make sure your wishes get honored over time. Again, we provide a lot of support to people who are coping with a new serious diagnosis. Sometimes people saw things coming, but many times they did not. We care for people who had unexpected strokes or, fell down and injured their leg, and when they got CAT scans, found that they had cancer all over their body. So as you can imagine, people's coping can really, just cover a huge range depending on whether an illness was expected or not. This often leads to a great deal of spiritual or existential suffering. And so we try to meet these needs, and we do have expertise in pain and symptom management. Hospice and palliative care physicians often are comfortable managing pain and pain medications in ways that many other physicians are not. There are a lot of fears around pain medications in particular, a lot of myths out there that somehow they hasten death or that we're heavy-handed in hospice. It's not true. These medications, as any medication, can be dangerous when not used appropriately. Cardiac medications can be very dangerous if not used by skilled people. So you have cardiologists manage them. Same with hospice and palliative care physicians. Drugs like morphine can be dangerous when they're not used by skilled practitioners, but can be very safe and effective when treated by an experienced clinician. Often in the hospital, we're helping to determine things like hospice eligibility, for example. These are some photos of teams that I worked with previously. This was some of my interdisciplinary team from my group down in Queens, New York, where I was for many years. And you could see our chaplain and one of our social workers who has really taught me so much. But you can see that the sort of the center of all of our care is the patient and their people, so family or other friends and close individuals who are important to you. And we surround you with a whole team of individuals to meet your individual needs. Again, the things that I think we provide the best are good, effective symptom control. And we're getting involved when the usual things are not working anymore. So having that medical expertise from a board certified physician is really important to make sure that your symptoms are being managed well and safely. Again, we provide expert nursing and medical care I didn't speak to it, but many of our nurses and social workers and chaplains also go on to pursue advanced certifications. So while nursings go through nursing school and do all their regular rotations, there are other things they can do to specifically become experts in end-of-life care. And many of the people on our team have pursued these advanced certificates. We give people the time. I mentioned that neurologist who sat down with my family and how I don't remember how much time it was. All I remember is that it didn't feel rushed. We had the opportunity to make sure our questions were heard and answered in a way that was helpful to us. Get information. One of the key aspects of training in palliative care is around communication. We're talking about serious illness, and the words that you use and how you communicate things can be incredibly therapeutic and helpful, and it can also be incredibly damaging as well. So, in the past, the thinking was, well, you learn these things. You go through medical school, you follow some seasoned physicians, and you'll learn how to have difficult conversations. You'll learn how to take care of people at the end of life. What hospice and palliative care as a specialty is recognized is that these are skills. These are skills that you don't just pick up. They're skills that need to be intentionally developed over time. So expert communication is something we spend a lot of time in the fellowship thinking about. How do we conduct a family meeting? How do we make sure all the information is gathered and conveyed in a way that's helpful to people? And what is the appropriate setting and who needs to be there to make sure that happens in the best way possible? And that we're supporting people throughout. How are we doing with time? We're doing well. Okay, so that definitely got through the majority of the topics that I was hoping to get through. I think there are some questions that I did not touch on in the talk that maybe Kim, you can help.
Yeah, I'm going to stay off camera just because
that sounds great.
A bit of an issue here. But yeah, I've looked through you guys. The participants sent in wonderful questions, and I've looked through these, and you have answered so many of them, Dr. Moreno. There are a couple here. And you kind of touched on this. How do we change the preconceived notion that hospice just gives a lot of medication and the patient dies from that? Do you have any ideas around that?
Yeah, I think it needs to happen on multiple levels. Some of it is what we're doing here, having open conversations about what the care might look like, the different sort of team members that are involved, and kind of thinking about how there may be more of a role for one than the other. I think what happens is that most people's experiences are that hospice gets involved in those very final hours to days. I showed you that graph and talked about how patients are often referred to hospice very late in their illness. It's often when somebody is dying and really kind of suffering that we get that referral. So what I remind families is that, your loved one came to us because they were dying and because they were uncomfortable. We're often starting to use medications like morphine, for example, in those situations to address those symptoms that haven't been controlled in an individual who's already dying. What people see, though, is that, geez, my loved one went to hospice, they started giving some morphine, and then they died a day or two later. And so we'll often make these associations. Well, it must have been the medications. I think oftentimes we're not doing a good job of helping communicate that individual was in the dying process when they came to us. Our intention in giving those medications is not to end somebody's life or hasten somebody's life. It's to relieve those symptoms. But both things are happening simultaneously. Somebody is dying while we're in the process of trying to address those things. And so I think for the untrained eye, especially when there's a lot of fears and worries and a great deal of mistrust, there's lots of historical reasons for people to be mistrusting of the healthcare system in general. I think that those things sometimes reinforce these fears. At Hospice of Southern Maine, we're incredibly transparent about what medications we give, what the indications are. We feel that knowledge is power, and so the more we can educate people to understand why we're giving certain medications, what the indications are, and how we monitor sort of the balancing safety and efficacy. I think people feel more reassured with with that information and the medications that we're using.
That's great. And this is personally for you. How do you keep from being overcome with sadness when working with hospice patients? I know some of these stories obviously
Yeah.
touch you.
I was gonna say, well, as you can see, looking at a photo of Marion and thinking about those, those days certainly brings about emotion. And I've always been somebody who's been very emotional and thought that I maybe even couldn't do this work because I do tend to, come to tears pretty easily. I find that it's a strength. What I tell students and residents who are rotating with me is, put yourself in the patient's shoes. If you were sharing a difficult experience and your physician shed a tear for you, that would probably feel pretty good to know that somebody actually cares and that that you matter to somebody in a genuine way. It's a little different if you're overcome and the patient's now consoling you. So I do my best to be genuine with my emotions and be real, but I also have mechanisms in place to care for myself. We know that this is a field where you're exposed to a great deal of suffering. Just this weekend, we saw a number of young people and, situations that can be really hard. And so I'm very proactive, things like physical exercise and nutrition, go a long ways, good sleep, having colleagues and professional opportunities to debrief cases and, talk about some of the more challenging ones. But you have to be very engaged with processing your emotions and thoughts as you do this work. If you don't, it will come out at some point. So, the more proactive you are about sort of knowing that you're going to have difficult experiences and really doing everything you can to develop your resiliency. But I would say more than anything, this work, it's an honor and it adds to my quality of life. Because I see so much, I think I'm maybe a little bit better at not taking people for granted in my life. I call my mom often and, I try to think about those little things and not take any day for granted and not take anyone for granted.
I'm sure your mom's happy. That's wonderful.
She would say I could call more often.
One more question, and we usually get this one. How does Hospice of Maine support people who choose death with dignity?
Sure. Yeah, that's a great question and something that I know a lot of our nurses are encountering when they talk to people in their homes. So as a hospice and palliative care physician, part of my expertise is knowing everything I can about end of life. And in the state of Maine, people do have their right to have the ability to pursue their rights under the Death with Dignity statute. So as an expert in end of life care, it's important that I be knowledgeable about the law and the statute. Now, I have a foot in both worlds. In the hospice world, we have a very clear policy here that we're neutral with regards to people's individual desire to pursue the act. So we neither encourage it or discourage it. We're not the ones sort of walking people through this process, and we're not the ones prescribing the medications as part of the act. Those are handled by their primary care physicians. We encourage people who are pursuing the act to have hospice care in place because your family and other people may have needs that we can be helpful with. And we can be supportive in a variety of ways. So we don't, for many years we talked about how people have fears of drugs like morphine, and for years we've battled the myths that are out there that somehow hospice is hastening things, and the mission of hospice is never to hasten death. It's to allow the process to unfold naturally and to support people through that process. So because it's part of our mission to not hasten death, as an agency, we choose not to participate and prescribe. But many patients are pursuing this in the community, and many of our patients have informed us that this is something that they're pursuing. So when we hear that, we want to make sure that we're doing everything we can to support that patient, making sure that any worries or anxieties they have been tended to, that we're trying to address the things that have them most concerned. We find that many times when we do that, people are no longer interested in pursuing death with dignity. We do some planning, we talk to your family, we put some things in place, and sometimes people, feel better and are happy just to know that they have an option. again, and on the palliative care side of things, I personally do not participate in any sort of death with dignity evaluations. Because of my role as medical director, I think it's important to have a clear sort of distinction. But there are many providers in the palliative care world who are having these conversations with patients and helping them make decisions about whether or not this is something they choose to pursue. The law is very clear about what the requirements are. People need to have sort of the capacity to do this. It needs to be a self-directed sort of process that happens. People need to be free of coercion and a number of things. So there are a lot of sort of legal and ethical requirements in place. But it's something that I think, and especially in Maine, where people are very sort of proactive and great advocates for their own rights and health, that it's something people want to know about. So, many times we're directing you to individuals who have better information, but it is something that we do sort of come across and have learned much more about in the last couple of years that it's been in place.
Thank you so much. I think our time is up. Maybe I'll come on screen with you if I can.
Thank
now.
you.
You can come over
can
still,
come with
but
you.
thank you so much for this. Was so informative, and just your expertise in this is just so heartwarming that someone like you is providing care in our community and training other people to do it. So thank you so much for that. And we did have other questions. I'm sorry about the little bit of snafu we had with our setup here, but we did have some other questions, but a lot of them could be answered. Some of them are topics in themselves, and you can go to our askhospiceexperts.org website and find information on advanced care planning, pain and symptom management, and a lot of other topics that people ask pointed questions on that we just didn't have time to get to today. So as always, thank you for being here, and we really appreciate your interest in hospice topics.